Hello, everybody. Thank you and welcome to this I3 session, an insightful webinar focused all things vitrification. We are excited to invite you to this webinar sponsored by Cook Medical, where leading experts will share their knowledge on key aspects of vitrification in the lab. This is a unique opportunity to gain expert advice, practical tips, and valuable insight that can help enhance your lab practices and improve outcomes. Don't miss the chance to ask the questions. This webinar is kindly sponsored by Cook Medical. We will keep the bios short this evening, but the full extensive resume of the careers of the experts here tonight can be found on the I3 website. Today, I'm joined by two co-hosts. The first host is Kanako Okamoto. Kanako is clinical specialist in Cook reproductive health. She had worked as a clinical embryologist in Japan for more than 10 years and concurrently researched biology and genetic aspects of endometrium stem cells. Before becoming an embryologist, her first experience of research was cryobiology for parasites in Kobe University, and this experience led her to human IVF. Welcome, Kanako.
Thank you, Magdalena. Thank you for the introduction. To reciprocate, the Magdalena is an experienced embryologist, PhD in science of biology, the passionate about the embryo development and implantation. The Magdalena has the MBA diploma. She is graduated with the various leadership courses. She is leading the global clinical specialist team at the reproductive health in Cook Medical. Passionate about combining the education and the scientific expertise with martial knowledge in supporting embryologists all over the world. Giles, I'm sure you all know as a clinical embryologist with a long career in ART and the executive director of this educational platform, I3.
Thank you very much. It was a pleasure to be here this evening, and it promises to be a fantastic session. As we said, please ask your questions in the Q&A section and not on the chat, and that's the best way that we can see them. Without further ado, we'll start. Our first speaker is Jeremy Chang. After being an embryologist at Lee's Women's Hospital in Taiwan, he then joined the xenotransplantation project of porcine cloning at the Animal Technology Institute, again in Taiwan. He then joined the Center for Regenerative Biology at the University of Connecticut in 2001 and obtained his PhD a few years later. He's currently an embryologist at the Reproductive Biology Associates in Atlanta, USA. His main research lies with oocyte biology. It's a great pleasure to have you. Take it away, Jeremy.
Thank you, Giles, for a very nice introduction. Today, my topic is about dangers of devitrification and the handling of vitrified cells. So in the daily IVF practice, there are three conditions we may face for the risk of devitrification. And number one is the handling condition. Number two is the shipping. And then three is the storage condition, especially for people who are using the vapor phase storage. We may have those risks. So the best way to prevent it is to avoid expose the vitrified cell and embryo to the temperature above the devitrification. However, practically it is impossible because we have to move the specimen in the lab, like do the shipping and do all the handling. So, but at least we have to know how soon the heat can conduct to the eggs and the embryo on the quiet device to reach to the temperature above the devitrification. So there was a very elegant study published on RBM Online. So the groups by Sensinina, they were using bovine oocyte to simulate 3 different conditions. One is a handling, and one is a shipping, one is a storage. As you can see this table, there are 3 groups. Group 1 is simulate the storage, which is -96 in the liquid nitrogen. Number 2 is the shipping. Shipping condition is -165. And number 3 is handling condition. They expose the bovine oocyte, the vitrified bovine oocyte, to -17 for 15 seconds. And as you can see here, number 1 and number 2, the egg survival rate and the blastocyst formation rate was not impacted. However, for the number 3, only exposure for 15 seconds at -17 degrees, you can see the survival and the blastocyst rate drop. So among those 3 groups, only group 3, the temperature was above the vitrify point. So to achieve a successful cryopreservation, the first principle is to eliminate water in the cell to avoid ice crystal damage. So especially for the vitrification, it is using the same concept. So basically, we use a very highly concentrated cryoprotectant, CPA, and then to get rid of the water from the cell, and then combined with extremely rapid rate of cooling and warming, and to avoid the ice crystal forming inside the cell. So here shows how we remove the water from the cell in the vitrification process. So on the left, this is the egg put into the culture media. So it's a very round shape oocyte. If we put the oocyte into the equilibration solution, which has the permeable cryoprotectants like ethylene glycol and the DMSO. So basically, we use this permeable cryoprotectants to replace the water inside the cell. So in the beginning, we will see the eggs will collapse because the water going out is faster than the CPA going in. And then it will take a few minutes. The oocyte will recover to the round shape, which reach to the equilibrium. And then we put the eggs into the VS solution. In the VS solution, we use an even higher CPA, try to replace. And also we use the non-permeable CPA, try to push the last bit of the water from the cell. So you will see the shrunken oocyte before plunging into the liquid nitrogen. So when we added the CPA into the solution, it also changed the thermodynamic properties, such as devitrification point and also melting points. So using DSC, differential scanning calorimetry, we are able to measure the heat releasing or absorption. By doing so, we are able to measure the devitrification temperature because the vitrify point is a heat release process. It's moving from the vitreous state to the ice structure. And for the melting point, it is the opposite. It's a heat absorption. So here is a thermogram derived from the DSC. So in this study, the author used the VS solution is for the embryonic stem cell vitrify. So basically, the content is 20% ethylene glycol, 20% DMSO, and 0.3 molar sucrose. So as you can see, there are some valleys and peaks. The valleys here indicating the devitrify. It's a heat release. And the peaks here, it's indicating the heat absorption, which is a melting point. So for the VS solution here, the devitrify point is -106. And then the melting point here is about -25. And one thing is very interesting here is if the author increase the CPA, you will see there is a trend. The devitrify point, the range from the devitrify point to the melting point, it's getting closer. Okay, and then this is the VS solution we usually use in our IVF lab. We use this for the embryo freezing and also egg freezing. So it has 15% EG and 15% DMSO and 0.5 molar sucrose. So the melting point for this kind of a recipe is about -18. And for the devitrify point, it's about -110. Okay, so this is cooling without any CPA with the pure water. So the ice formation zone is starting from freezing point, which is 0 degrees C. And then the other end is -146, the glass transition temperature. So basically from 0 to -146 is an ice formation zone. So when we do the cooling, in order to avoid the ice, we need to use extremely high rate of the cooling in order to reach the vitrification. However, if we add the CPA into the solution, we can scale down this ice formation zone. So basically it's starting from -18 to the glass transition is -30 degree. So compared to the pure water, this ice formation zone is much shorter. Therefore, it allows us to use a slower cooling rate without forming the ice. And then, for example, for the cryo top, the cooling rate used 60,000 degrees C per minute would be enough to vitrify the reproductive cells without forming the ice inside the cell. Likewise, for the warming process, if we use this recipe of a VS, and then the ice formation zone is starting from -110 to -18. So this ice formation zone is even smaller. Okay, so now we're using the cryo top as an example. The warming rate is basically based on the numerical model and also experiment model. So the warming rate is about 96,000 degrees C per minute. So if we convert into per seconds, the warming rate is about 1600 degrees C. So from the liquid nitrogen's temperature to the devitrified temperature, it is about 86 degrees apart. So 86 divided by 1600 degrees C, it's equal to 0.053 seconds, which means if we warm the eggs or warm the embryo, use the cryo top, it would take 0.053 seconds from liquid nitrogen temperature to reach to the devitrified temperature. And it will take another 0.05 seconds to pass through the ice formation zone. And then we try to simulate the devitrification. So when we expose the vitrified sample to the air, especially the cryo top with a cap, the purpose of this simulation here is for the scenario like the lab incidents. So for example, if we drop the cryo device on the floor or on the bench, do we have enough time to rescue those reproductive cells. So here is the warming rate with a cap. We can do a little calculation here. The warming rate with a cap is 612 degrees C per minute. So it's equal to about 10.2 degrees C per second. So from the liquid nitrogen temperature to the devitrified temperature is 86. So it's going to take 8.4 seconds to reach to the devitrified temperature. So that means you have 8 seconds to rescue those cryo device or the reproductive cells. Okay, in the other scenario, if the cryo device doesn't have the cap, so as you can imagine, the warming rate would be extremely high, would be 7,850 degrees per minute. And it would take 0.66 seconds to warm the reproductive cell to reach to the devitrified temperature. It will be less than a second. Okay, the other question here is, how soon are we going to see the damage after exposure to the temperature above devitrification? So to answer this question, we designed a study using -80 degrees C to devitrify human oocytes. In order to keep it at -80 degrees C, we use ethanol bath. So therefore, we were using closed cryo device, which is rapid eye, as our for our experiments. And then, as you can see here, there are basically we have 3 treatments. Number 1, 0 minutes. That's the control. Number 2, we have 10 minutes. 3, we have 1 hour and 24 hours exposure in the -80 degree. Here is the outcome. As you can see here, the control basically just like what we do the regular oocyte warming. So directly warm the eggs from liquid nitrogen to the 37 degrees C. So the survival rate is about 90%. And then if we expose the oocyte to the -80 for only 10 minutes, the survival rate didn't change much. However, for the group number 3 and number 4, the exposure time reached to 1 hour. We did see the survival rate drop significantly. And if we look at the before and after picture here, so if you notice in the 1 hour, before and after, so especially after the 1 hour exposure time, you may see some blebs on the surface of the membrane. So it's evidence indicating the ice crystal formation did some damage. And also, if you look at the 24 hours, so you may see some fracture zona. It also indicating the large ice crystal damage. Okay, so basically there are 2 stages to cause the damage. So 1 is a devitrification, 2 is a crystallization. And then crystallization is the ice nucleation and also ice crystal growth. For both of them, it takes time. So maybe this is the reason why when we expose the vitrified eggs for 10 minutes inside the -80 degree, it didn't do too much damage. And also crystallization rate is temperature dependent. So according to Dr. Seki and Mezer's estimation, so every 5 degrees C increase is going to increase 5 times. So the crystallization increase will be exponentially. Okay, so here the conclusion. So the best way to avoid the devitrify is we try to avoid to expose the vitrified eggs and embryo to the temperature above devitrification. And secondly, the higher the exposed temperature, the higher of the ice crystallization rate. So number three, a cryo device with outer cap can slow down the heat conduction to the specimen. So let's say if you have a lab like incident happen, it's going to buy you some time to the rescue. And this is the end of my presentation. Thank you so much. So I'm going to pass the floor to the moderator.
Thank you, Dr. Jeremy. This is a fantastic presentation. Can I ask the question?
Yes.
The legal forge. The safety of the oocyte embryo is the most important things for everybody during the vitrification, I think. They are even stored in the liquid nitrogen tank, not the bypass phase. We repeatedly pour in and out the goblet into the liquid nitrogen tank in the daily works. So this means that there is a risk of the devitrification, I think. Additionally, due to the increase of the social freeze, the storage duration is getting longer. So what kind of thing we should more be careful? Can you give us your advice?
Yes, it's a very good question. Basically here is, so based on the presentation, we know what's the time it's going to take to warm up the vitrified cell to the devitrified temperature. And then if we can work within that time frame, especially when the cryo device doesn't have the cap protected, so the temperature increase will be huge, which will be very fast, especially without the cap. We need to handle it very carefully.
Okay, it's good to know. Thank you for your information. Okay, so now let's move to the next presentation. Okay, great honor to introduce the Dr. Juergen Liebermann. He did his doctoral thesis at the Technical University of Munich in 1995 and the postdoctoral thesis in 2004 at the Charles Maximilian University of the Würzburg. Since 1996, directing the IVF laboratories with relocation to the US in 2004. He is proud father of 5 children, the marathon and the triathlon finisher, and the mountaineer, licensed scuba diver, and finally the artist as well. Dr. Juergen, all yours.
Thank you very much, Kanako, for this kind introduction. And thank you for the International IVF Initiative to invite me back to this very always well-attended and prestigious webinar. I want to talk about today vitrification of oocytes and embryos, and are there any factors we should be concerned of? And I decided to go back in time 20 years back when we had to make this decision from slow freezing to vitrification, where we had to face similar questions about of the unknown and the concerns in regards to vitrification. And as a little bit of a reminder, what we're talking about, traditional slow freezing was first published by Whittingham, Leibo, and Masur in 1972. And you see how these penguins move in the water very slowly compared to the right side with the first and actually a landmark paper on vitrification in 1985 by Dr. Rall and Fay, where you literally plunge embryos in liquid nitrogen in seconds. This is an example how we froze zygotes in the mid-90s. And when you see the protocol was set up in different temperature ramps, where you gradually increased or decreased the temperature The longest step finally was from the seating at -6, that you did manually, to about -30 in 0.3 degrees Celsius per minute, and then you plunged it. But overall, this protocol took about 89 minutes to complete. When we started thinking about vitrification, and we compare the cooling, slow cooling, traditional slow cooling, and vitrification, both protocols, of course, represented a challenge for every living cell. Could be mechanical damage on the cells in form of ice crystals, osmotic swelling. There could be an impact from the cryoprotectant in terms of toxicity, chemical damage, and of course, because of the temperature we expose, could be a thermal damage in terms of chilling injury or cold shock. And especially for oocytes, it was really hard to vitrify a cryopreserve in general, because it's the largest cell in the body. It has a high content of water and a single membrane. When you deal with large cells, they usually have a low surface area to volume ratio. That makes it less efficient to take up cryoprotective ether and to lose water. In addition, you have alterations on the homolemma that includes low permeability to water, and it's also a major site for cryo injuries, and it can destroy the membrane and its integrity. And finally, you have temperature-sensitive components, such as spindle, the sonar pellucida, and then the inner cell organelles like microfilaments, alterations to microtubuli locations, and mitochondrial organization. And when you look at the history of egg freezing that was published first successfully by a paper from Chang from Australia in '86, there was a very, very slow development. Years later, Germany followed with 2 publications. When it took a longer break, about 8 years, until Eleonora Porco from Italy published successfully egg freezing in '97. Michael Tucker, US, followed, and so on. And then we got also first vitrification paper from Kuleshova and Katayama from the US and Australia. And still people worked on changing the slow freezing protocols, for example, Quintas from Argentina in 2003. So this was not an easy switch, many people were not convinced and had their doubts. But when you looked at the results in terms of slow freezing, they were not overwhelming convincing. Conventional cryo protocols leading to low overall success rates of about 1% implantation per egg frozen, published by Mandelbaum in '98. The developmental potential up to the blastocyst formation is only about 6%, published by Kobo in 2001. And finally, there were some attempts to improve the freezing by injecting Frialos by Aeroglu in 2002, but always baked a little bit hope that we can continue slow freezing. But overall, the slow freezing, when you now see here the history in terms of cryopreservation, it goes to 2008 or 13. You see here the first yellow band, the survival rate, always less than 60%, around 50%. With vitrification, we were able to top it about 80% or even higher. Fertilization already higher than the slow freezing, 70% versus 85%. And finally, and I think the most important aspect, when you slow froze eggs, it took about 74 eggs to achieve 1 live birth from slow frozen eggs. This number we were able to drop down because of the outcomes, the survival and the quality of the warming, when we use vitrification, to 27 oocytes per live birth. So when we think about this instrument we use for the slow freezing, there were planners, there were definitely not the future, there was no alternative. So what was the alternative? A liquid nitrogen bath. And if you do this right, and you plunge your cells correctly, you should exactly get what my previous speaker showed, and I have the same picture here, a similar picture, what I took in 2000, where I exposed a dish containing 2 drops in liquid nitrogen. and one drop just contains DPPSO, and the other one 2 cryoprotectant. And the main difference, immediately you will face it, you see 2 drops with different color. Both drops are at the morph phase, but one was created with by ice crystals on the left side, and the right one is ice crystal free. That's what we call vitrification. It's called the glass formation. In 2003, I gave a talk. I was invited by Alpha in Belgium. And you see here, my topics are very actual. Actually, we talk about the same things today. And I was talking about vitrification, the cooling rates, how important. We didn't talk much about warming rate. We now know that's even more important. We talked about carrier systems. We talked about potential shortcomings of vitrification techniques and solutions, how we can solve these problems. Are these techniques easily adaptable to IVF labs? And what's the current relevance of vitrification in art? And then we talked about why we should use vitrification compared to the well-established but not successful slow freezing. Minimize mechanical damage and osmotic stress. Minimal chilling injuries, no fracture of zona. No ice crystallization. Control of the dehydration rate. Reduce the time of the cryopreservation procedure. Very simple protocols. And finally, eliminate the cost of the freezing equipment and their maintenance. In addition, maintenance of physiological temperature during equilibration. Small volume used provides a significant increase in the cooling as well as warming rate. Permits the use of less concentrated cryoprotectant, so we can reduce the toxic potential, toxic effect, and favorable technique for cold-sensitive cells, such as oocytes, or even for more complex cell types like the blastocysts. So what are the shortcomings of vitrification at this time? And we figured out, it requires at the same time very high cooling rate, and we learned later by Seki and Peter Masur also high warming rates. Protection from potential toxic chemicals, and this is biologically problematic and technically difficult. And then in addition, direct contact between the vitrification solution containing the cryoprotectant and the liquid nitrogen as a potential source of contamination. So how we can solve these problems? And one part was a huge amount of different carriers were developed. And what you see here is a cryoloop, and it contains, for example, 1 egg. But these carriers allowed to load cells in a very small volume, where we believe that will support and helpful for the high cooling rate to achieve vitrification. This is another example of a cryoloop. It contains here 5 oocytes, and they stay there in this loop based on the surface tension. So ASRM guidelines until 2013 considered egg freezing as experimental. They recognize the improvement in survival, in the fertilization, also in the blastocyst formation out of these thawed oocytes. And they also recognize there is definitely that these vitrification protocols on a long-term superior, but they requested when you do egg freezing, you need an IRB. That means it was experimental. And this brought a lot of good, excellent scientists up to do research. And you see here, Michelle Lane and David Gardner, they did studies on the metabolic health. They looked in the oocytes, control, vitrification, and slow freezing, and then how is a pyruvate uptake. And you see here that actually the worst scenario was when we froze the egg slow. On the other side, you saw, for example, Mark Larman and his group did some studies on zona hardening, and by adding calcium to the vitrification solution, we were able to delay and reduce the hardening of the zona. Of course, we talked about the meiotic spindle and the beta tubulins, and you see here some nice studies from Chen and Chang in 2009 and Gomez in 2008, and they figured out, and we know that the meiotic spindle is very vulnerable to the temperature changes and will depolymerize. But they also figured out if you put it back to 37 degrees Celsius, the microtubules are able to repolymerize, and this happens much faster as it happened in eggs that were traditional slow frozen. And of course, when you look at the beta-tubulin, they do the same thing, they depolymerize, but in a 2-hour window period later, beta-tubulin repolymerize, forming a morphological and normal metaphase spindle with properly aligned chromatin. So you see, in this time, a lot of issues, and of course, nobody knew about, so it was very important to do this research. And another paper by David Gardner and his groups, by looking in the protein profile of control oocytes, slow frozen oocytes, and vitrified oocytes, and then, the upregulation or downregulation from these oocytes. And when you look to the graph on the right, you see on top in vivo and vitrified oocytes. And if you go down on this heat map, you see very, very less differences in the color of these two cell types. But if you look to the far right, slow frozen oocytes, you see definitely different pattern here, different up or down regulation of proteins compared to the control or even vitrified oocytes. And that was also a conclusion here. The study on mouse oocytes following slow freezing reveals major alteration compared to those that were vitrified. And finally, vitrification also showed that does not appear to increase the risk of abnormal imprinting or disturbance in spindle formation or chromosome segregation. Then a nice big study from different countries, from NYU, Dr. Noyes, and from Italy, Dr. Porco and Andrea Borini. They summarized in 2009 the babies born from slow freezing and from vitrification, and their conclusion was no increase in anomalies from these babies from vitrified or from slow frozen oocytes. And finally, a meta-analysis from Dr. Oktay in 2006. And you see here, when you just go through fertilization rate, already improvement, clinical pregnancy per thawed oocytes or per injected oocytes doubled. I know you will smile about these numbers, but these early numbers showed already a trend. And even in the clinical pregnancy per transfer, it doubled like more than 20 to 45%. And the implantation also close to increased twice from 10 to close to 18%. So a lot of numbers convincing, a lot of publications, and you see the trend. And I just recorded until 2013. Every year we had a tremendous increase in papers in not just IVF, in agriculture, in medicine, in veterinary science, on the topic of vitrification. And today we face a new problem, a new challenge with the fast and furious. And you have here a nice study recently from Dr. Shao from Japan, and they used mouse oocytes, and they compared survival first and between control, traditional vitrification, and ultra fast. And you see the traditional vitrification was 10 minutes in the first solution ES and 1 minute in VS. And then the ultra fast was a total of 2 minutes, 1 in ES and 1 in VS. And you see the survival in the fast was already significantly higher to the traditional conventional freezing vitrification technique. They also looked in intracellular compartments. For example, they looked in the distribution of the mitochondria, their membrane potential as an important key factor for their activity. They looked into the inositol triphosphate, that is a major component of membranes in the cells. These two cell components, they were in favor of the ultra-fast vitrification. They looked at the spindle, and good message here, there was no difference if eggs were slow frozen. It's a traditional vitrification way or the fast way. But they also looked finally in the volume. When you fast vitrify oocytes, there is less volume reduction, not as extreme as you do it when you do it the traditional way. where you let them re-expand and then shrink them again. So this is also in favor of the fast. And finally, they looked into fertilization, cleavage, and blastocyst formation. That was also in favor of the ultra-fast compared to the conventional vitrification. And when we have studies we need for clinical evidence that we can move on to provide it to our patients. And this was a study by Abirol here recently as a webinar. He also had this at an Escher, an oral presentation. And you see here, he compared ultra-rapid versus standard vitrification. And you see here an increase in fertilization. The day 3 development is quite similar, but a higher blastocyst formation. Of course, the rate of ovulate embryos was not affected because we saw before spindle were also not affected. Now, what we face in addition to what I just mentioned, we have 4 concerns, and I want to list them here. The interchangeability in terms, of course, of media we use today, how we can work with different brands of this media. Does it affect our outcome, survival, and development? Second one, do we need to load oocytes only 2, or can we even go higher? A topic that was very much discussed in the mid-90s about contamination of nitrogen of the solutions, because virus was shown has the ability to survive in liquid nitrogen. And finally, we can finally have a universal protocol where we can freeze egg zygotes on cleavage stage embryos. And I did a couple of studies here using different media, sage, Vitrolife, and so on. You see, I vitrified, for example, with Kitasado, when I split these oocytes, the sibling oocytes in sage and Irvine. And I did also Vitrolife, freezing and warming in Irvine, and so on. And I didn't see any difference regardless of the media I approached and used for warming or vitrification. So good messages. I'm very convinced that these media, if it's needed, are interchangeable. And there is a need for, because we have more patients whenever they move around, and we get embryos from different locations where they also employ different freezing media. My second aspect, I want to come back to what I talked about in 2003 and 4, closed versus open system. Very briefly, what's the difference? There is different when you have a closed system. There is not a direct heat contact. So because your carrier creates a wall, and so we will have a lower cooling rate that might have an impact on a successful vitrification. And open systems, very simple, where you actually can achieve a maximum of cooling rates because you have no reduced heat transfer because of a direct contact of your sample with the liquid nitrogen. And I did some studies because for many years, it was actually a doubt that oocytes can be frozen on a closed carrier. Although it was already published by a group from Belgium 10 years ago, I did also hear some studies using the high security vitrification kit, Irvine media, and then I used the rapid eye Vitrolife media, and you see my 28X on the Irvine media survived to 96%, and my 29 I vitrified on the closed carrier rapid eye from Vitrolife survived to 100%. So we definitely get here sufficient cooling rate was my point, warming rate anyway, but cooling rate to use this closed system successfully. I want to talk about briefly 2 oocytes only. This is very time consuming. We need a lot of carriers. We need a lot of cryo space. And so, I did some studies here. For example, I used my own protocol that is 2 minutes, 1 minute in ES, 1 minute in VS. And my warming is also 2 minutes, but I start with 0.5 molar and then 1 minute in WS. I froze 16 unfertilized metaphase 2 oocytes on 2 cryologs each with 8. It took me 3 minutes and 35 seconds, and the warming happened by thawing them all together, and it took me 3 minutes and 16. So a very efficient way to also cryopreserve a big number of oocytes. And on the right side, I use sage media. You see here 7 abnormal fertilized metaphase 2 oocytes, so zygotes. and you see it took me 2 minutes and 30 seconds, whereas the warming was about the same, 2 minutes and 23 seconds. Always survived. And you see here 33 eggs I vitrified with sage on 4 cryologs, and with my protocol I got 100% survival. And finally, about a universal protocol, I try to vitrify all different stages from a GV to a metaphase 1, phase 2, even abnormal fertilized zygotes and cleavage stage embryos. And you see here big numbers I did over time. I always achieve more than 90%, actually mid 90% survival, regardless of the cell type. And I want to use that opportunity before I come to my last slides here to recognize the research and the publication on a one-step warming by Stanley Lipo, published in '83, El Gaillard in 2001, and just recently by groups on Mons and Taylor. They got prize papers at the PTRS and abstracts, recognized abstracts at the recent SRM meetings. And I want to show you our results so far. We have 3,300 frozen transfers using our 1-minute thaw now. And you see, regardless of age, there is a consistency in a positive beta beyond 70%. Only patients over 40 drop down to about mid-60. Overall, for all ages, is it close to 72% positive beta. So far, we can report 751 live births out of 1,421 transfers. That brings us to a live birth rate close to 53%. To summarize here, my future I see in vitrification: short exposure time during equilibration, that means dehydration; short time for warming, that means rehydration. I also think that direct rehydration for blastocysts, so no sucrose exposure, is visible, and vitrification and warming of oocytes and embryos will be simplified. If we consider this all, it will give us consistency in survival, in ongoing pregnancies and implantation, and in live births. Thank you very much.
Thank you very much, Dr. Liebermann, for fantastic presentation. I would like to ask you now one question. You mentioned in your presentation short-term results of the cryoprotectants influence on the short-term results after vitrification. Data on high cryoprotectants association and epigenetic mechanism and long-term consequences remain, however, conflicting. In your opinion, does cryoprotectants remained during fast warming can affect an epigenetic status of the offspring?
I know I cannot just answer with my feelings. It needs scientific data, so there is no questions. You know, we have to do always step by step. We have to start looking into these protocols. We have to see, do we see a benefit, not just in the workflow, but also in survival and development. And of course, it's like the same scenario when we switch from slow freezing to vitrification. There is no difference. We have to look on long-term effects. There is no questions. But I think less exposure to cryoprotectant because of a shorter time of dehydration or rehydration will be beneficial for the oocytes and embryos. So we reduce the time, you know, they are able to load themselves with the cryoprotectant, what we consider to some degree toxic. But I think the time is so short that this toxicity that is not well defined, what we actually mean, is has no chance to have an impact.
Perfect. Thank you so much. You may stop sharing your presentation. We have much more questions to you that we will come back to them later. And now I would like to introduce our next speaker. Our next speaker is talking about practical experiences. Eros Nikitos is the laboratory director and senior embryologist for the Institute of Life IVF Clinic, IASO Hospital in Athens, Greece. He's known for pioneering research in embryology, particularly in maternal spindle transfer. He co-authored the first pilot study on MST aimed at treating idiopathic infertility and repeated IVF failures. This innovative technique involves transferring nuclear material between eggs to enhance fertility outcomes. Eros Nikitas, along with his team at the Institute of Life, has over 20 years of experience in clinical embryology. The floor is yours, Eros.
Thank you, Magdalena, for your kind introduction. My talk today will be based on best practice in vitrification and warming from a busy lab setup perspective. So this is what we do usually in our labs, and this is the place where we perform our magic. This is some fun numbers from our center, just to give you an idea of the numbers and of the volumes that we handle each day. We will be talking about vitrification, and last year we have performed more than 15,356 embryos and oocytes vitrified. So it's quite difficult for me to think of a procedure carried out in the embryology laboratory that is not directly linked to the vitrification technique. The optimization of vitrification techniques has made it possible to create more efficient cryopreservation programs for both oocytes and embryos. For oocytes, we applied in cases where there is no sperm recovery on the egg retrieval, for egg banking, for fertility preservation, both for social or medical reasons, and oocyte donation programs, including transnational oocyte donation programs. As for embryos, such as freezing of remaining embryos, freeze-all cycles, or PGT cycles, pending genetic results. It is apparent that creating an efficient cryopreservation program has been shown to increase the cumulative live birth rate per cycle. Regarding the embryo vitrification, here we can see several publications analyzing that the most predictable variables and morphokinetic factors after vitrification and warming, and concluded that the embryo survival rate is linked to embryo quality and that its success does not depend so much on the stage of embryonic development. That means cleavage stage embryos or blastocysts. Now let's move on to the optimization of oocyte vitrification. As you well know, it's the largest human cell. It has very low area volume ratio, high water content, and high intracellular complexity. The exchange of cryoprotectants and water through the membrane is carried out by simple diffusion instead of diffusion channels, as occurs with a blastocyst. The membrane permeability of the oocytes is very inefficient and very slow. So this is what a setup for vitrification and warming looks like in our lab. So it's very important to define which is the setup, to follow, to keep the orientation of the gear in the same place, to try not to leave unnecessary equipment on the spot. Here on the left side of the image, you see a vitrification setup, and on the right side, you see the warming setup. It's very important to keep everything very neat. This is a video, 3 videos in a row, that you can see the process of vitrifying, in this case, a blastocyst from a patient. In the last, you can follow the whole process. It's from putting the embryo into the vitrification dish, going through the media, going through the procedure, and then at the end, loading the cryotop and trying to design the perfect droplet. Witnessing both electronically and physically all steps of vitrification procedure is mandatory. We need to ensure that we vitrify the right patient embryos, right embryos in the right straws, and straws used need to display the right information. Just allow me to share some of our tips and tricks that we use and we have come along after years of experience in the lab. Lab conditions are very important in order to not affect our survival rates and to maintain seamless conditions. We need to oversee some variables and keep our conditions stable. Some of the more critical lab conditions are temperature and relative humidity. For that reason, it's advisable to keep vitrification media droplets high in volumes, follow strictly the protocol, and be sure to eliminate the presence of equilibration solution when moving to the vitrification solution. Try also to design a right size shape droplet during loading, as you see in the image. Try also not to start a vitrification round for more than 3 carriers. When we have more than 3 carriers to vitrify, we need to divide the rounds. We need to do 1 round and then another. Biopsy blastocyst needs to be vitrified as soon as possible after biopsy and tubing takes place. And pay attention when moving carriers away from the vitrification dish, because sometimes stickers get sticky and vibration can move specimens away from the vitrification carrier. Some consider the warming process much more important than vitrification. Here are some tips from our program that came up through the years. Most of the tips and tricks displayed are very common for most laboratories. From our experience, TS timings need to be more flexible because sometimes, especially oocytes, take more time to dehydrate, and some extra seconds of time inside TS might be necessary. This is a video of the warming procedure. Here you can see the cryotop plunging inside the TS solution. You can see the little dot, it's the blastocyst that floats. We quickly transfer the blastocyst into the bottom of the dish. And we try to leave the embryo until the timer goes off and until we see that the dehydration took place. It's strange to me sharing this information when Juergen is present. He had a very thorough presentation of the fast warming, a fast vitrification protocol, but it's important to acknowledge that this technique is revolutionary, especially for big labs performing many frozen embryo transfers. We have internally validated the protocol shared by Juergen, and we have experienced very good results. The protocol performs at least as good as the previous one, as the conventional one, and saves a huge amount of time for embryologists. Now let's see what happens for PGT embryos. Each re-expansion rate is directly proportional to the time between biopsy and vitrification. The morphological quality of the blastocyst and the day on which the biopsy is performed, day 5 is always better than day 6 or 7. For example, strict time frames to perform blastocyst biopsy seem to harm the results. In most cases, a biopsy is not a straightforward procedure, and embryologists need to follow embryo development and biopsy the blastocyst when it's ready. It has also been proven that total number of biopsied cells affect clinical outcomes. More than 10 cells can impact the implantation potential of the blastocyst, but a minimum number of cells must be biopsied to guarantee genetic analysis. Concluding, the recommending numbers of cells to respect both clinical and genetic results is between 5 to 10, ideally no more than 8. On the other hand, sometimes we are focused to perform multiple cycles of biopsy and vitrification on embryos, either for inconclusive results in the PGT or for those patients who decide to perform PGT of their embryos already cryopreserved. But is double vitrification safe? Well, several studies have analyzed these two scenarios, and what has been seen is that taking into account that the percentage of inconclusive results is currently low, only approximately 2.5%, when these embryos are thoroughly biopsied, a high percentage of diagnosis is obtained in more than 95.2% of them with a high percentage of euploidy, so it does not deserve to go unnoticed. In addition, all rebiopsied and revitrified embryos have a high survival rate. In some cases, there is a negative trend in the pregnancy rate and the abortion rate slightly increases, but these differences are not significant. Donor oocyte cryopreservation programs have been applied successfully in different countries. Today, there are many reference clinics that have established the practice with an efficient donor oocyte cryopreservation program with reported survival rates of more than 90%. When we compare fresh oocyte donation cycles with vitrified ones, comparable results are observed when starting from the same number of oocytes to inseminate after thawing. Vitrified oocyte cycles usually present a more compromised embryonic development than fresh ones due to the alteration of mitochondrial activity and distribution and the increase in oxidative stress. On the other hand, they also present different morphokinetic parameters, require greater energy expenditure and time of reactivation of the metabolic machinery in embryos derived from vitrified oocytes. While vitrification does not increase the risk of aneuploidies, nor does it decrease the potential for implantation, the probability of live birth increases with the number of devitrified oocytes used in the same cycle. On the other hand, homologous oocyte cryopreservation for patients seeking fertility preservation is becoming popular. More and more women, especially after COVID-19 pandemic, choose to preserve their oocytes, whether for medical or social reasons, before risky surgical interventions, premature ovarian failure, absence of sperm on the egg retrieval day, or for ethical or religious reasons where embryo cryopreservation is not acceptable. When we look at the scientific literature in these cases of oocyte cryopreservation for fertility preservation, what we must take into account is the following. As seen in the graph, the age of the woman is the key factor. Women over 35 years of age have lower oocyte survival and live birth rates. The cumulative rate of vitrified oocytes is directly proportional to the cumulative live birth rate. In young patients, called also elective freezers, similar results are observed to egg recipients. Whereas when elective freezers patients are compared with infertile patients, the latter presents poorer results. Cancer patients, regardless of age, achieve lower survival and live birth rates when compared to a similar control group of non-cancer patients. These are some of the data that we shared with a company offering vitrification system for the recognition program. We have shared more than 5,000 blastocysts, and here you see some numbers. And we have shared also some data on our oocyte vitrification and warming program. It's very important to understand that in order to establish and to maintain a very successful vitrification program, we need to follow some KPIs. We need to oversee and follow these KPIs every 3 months, and to train adequately all practitioners of vitrification. I guess we'll agree with this quote, and I thank you very much for your attention.
Thank you for your great presentation and beneficial info for everybody. Okay, I have not a question, but I want to ask you the advice for the junior embryologist. I think we have a lot of juniors in today's session. So during the training for the juniors to increase their skills quicker and also achieve the stability in their procedures. What kind of thing is the most important? What do you think? And can you give the advice for them?
I think practice, it's the key factor for vitrification. Performing more and more rounds of vitrification, it's very important. And this can be done through training offered in each center using discarded material or beads. I think it's very important for trainees to shadow for a certain time of period senior staff doing vitrification procedures. And there is a strange fact about trainees. When they initially start performing their own vitrification procedures, they tend to be more stable than the senior ones because there is a learning curve, strange learning curve for vitrification. Initially, you feel anxious about it. You follow strictly the protocol. As the time goes by, most of us we tend to be more relaxed and to be more relaxed about timings. So many times trainees overcome performance-wise even senior staff.
Okay, it's good to know. Thank you. So we received a lot of questions, but later on we have the Q&A session. So let's move to the final presentation. So Dr. Hamilton is the director of the Clinical Embryology Skills Development Laboratory and a part of the team running the MHSC in the laboratory medicine clinical embryologist field. Dr. Hamilton, all yours.
So thank you very much. First of all, I'd like to acknowledge the I3 organization for setting up these webinars. This is probably the greatest thing that came out of COVID to my mind. I'd like to thank Giles for inviting me to participate. And I'd like to thank the previous speakers for making my job a little bit easier. So thank you, Jeremy, Juergen, and Eros. So I'm gearing my talk more to the trainee and to the trainer. I can add some extra tips to this, and I like to use analogies. I think I did my first embryo freeze procedure in 1990. I've been roasting marshmallows longer than that, and I've trained lots of embryologists, and I've trained lots of people to roast marshmallows. Summer's just about over. So I want to give you just a little taste of the campfire. And although marshmallows are good, music is a little better part of the campfire environment. That's Jim Cuddy. I'm Canadian. Jim Cuddy is from the iconic band Blue Rodeo. And I'd love to be at his campfire when he was playing that. I have no conflicts to declare. I have no specific commercial bias, but I'm going to acknowledge the importance of our commercial suppliers to the ongoing quality of our work. So I'm going to really quickly cover the first bits because the previous speakers did an excellent job covering these, but I do want to just touch on cryopreservation of cells basic principles, a very brief history, and then kind of focus on achieving improved survival on an ongoing basis and applying these lessons from a campfire, or maybe applying lessons to the campfire. And yes, I will acknowledge important contributions to our continuing success. So we all know the birth of the first IVF baby occurred in 1978. Credit to Edwards, Purdy, and Steptoe. Freezing became very popular not too long after clinics got going on just fresh IVF. And I think the first live birth, 1984, Zalmaker. In the early days, we transferred tons of embryos. We actually froze multiple embryos at the same time. And although you didn't really see much quotes on outcomes, in 1990, I think the expected ongoing pregnancy rate per embryo transfer was about 18%. And for FETs, it was probably about 12%. And usually people quoted the pregnancy rates as just positive betas. Excuse me. So in order to successfully freeze cells and embryos, You got to do dehydration to remove the intercellular free water and prevent ice crystals. This involves exposure to hyperosmotic solutions. You're going to stabilize with different types of cryoprotectants. Here's the list that have been mentioned in the previous talks. You got to cool down to -196 for safe storage. And this is to keep metabolism down and reduce degeneration and infection. These things require energy. And then to reverse it, you got to bring it back to physiological temperature and get rid of the cryoprotective and rehydrate. Slow freeze was the longest standing so far form of freezing embryos. 1984 to 2015, it was probably still the most common form of freezing embryos in clinical embryology labs. Rest in peace. I'm not really sure it's rest in peace because it's still fairly widely used for, say, ovarian tissue freezing and larger types of material freezing. It involved fairly long incubation times for both the cryopreservation and thaw. It involved complex equipment with very detailed programs for temperature drops at 0.3 degrees per minute. And along with that, it required a lot of extra lab work in terms of maintenance of the equipment, quality control. This is a cryologic version, the planar version that Juergen showed you. And they were very simple carriers. So 1/4 cc straws. Essentially, when I did these talks to patients, I compared them to the ink reservoirs in Bic pens. Room temperature, long incubations until the final warming step. And this was the test start protocol that we all referred to for a long time. Okay, so vitrification has a lot of the same steps, but the impact of the operator, the embryologist. So equilibration, you still have fairly long and forgiving incubation period. So this one's got leeway. Then you've got exposure to the vitrifying stage of the cryoprotectant. This is actually quite brief, and it's got limited forgiveness, probably plus or minus 15 seconds. And this type of time frame and short incubation really puts the stress on people when they're learning. Loading to the carrier device, volume and loading time are actually critical. There can be dehydration, and it's actually included in that limited total exposure time. And then there's plunging and storage. And once plunged, as Jeremy pointed out, there's really no reversal that should happen. You got to keep it under liquid nitrogen and maintain it under that -196 until the thaw. And that you continue that throughout the care and your inventory management, because sometimes embryos and oocytes stay in your storage and under your responsibility for decades. And one big factor that people sometimes overlook is you can carry oil through some of these solutions. And if that gets onto your carrier device, it will certainly impact the survival rate. And on the warming component, rapid warming, you need to move it from the liquid nitrogen to the sauce solution quite quickly, but it also has to be a smooth, rapid movement, not too rapid. There's a physical state adjustment that happens. And probably if you flick it across your solution too fast, it can leave the embryo far behind your carrier and make it hard for you to find it, particularly when you're just learning. We get to use relatively large volumes of 37-degree thaw solution, and that's because you need the higher volumes to maintain that heat capacity. And then the rehydration and dilution as before. These are moderate incubation times, usually at room temperature for a lot of it. And again, these don't add stress or that much of a learning curve. And then several wash steps. Incubation in high protein media, which there's some evidence that this improves the re-expansion and recovery. Okay, so how can you apply life to this or this to life? So I like to use the campfire. And if we think of the campfire, you want to have, if you're going to roast a marshmallow, you don't want your fire to be roaring. You want to have the fire well established so that you've got stable embers at the bottom. It will give you a nice source of heat and a consistent source of heat. Then there's the object that you're actually going to roast. So is it a marshmallow? Is it a wiener? Is it a sausage? Did it come from the fridge? Did it come from the freezer? Did it come from the counter? Did it come from the cupboard? These conditions are going to affect the success of you roasting your marshmallow or your wiener. How about the tool that you're going to use to actually roast it? So, you know, traditionally it's a stick, then maybe a modified coat hanger, or now you got fancy purpose designed tools that are a lot more forgiving, easier to operate. And what issues can you come across while you're trying to roast your marshmallow? And this is lots of pressure for dad or grandpa as I'm teaching kids, nephews and grandkids to roast their marshmallow in a way that they're going to be able to enjoy it. So challenges you have are attempting to roast before the fire is appropriate. You know, you get that fire roaring and you want to get going at it. So you send the kids in to get their bag of marshmallows and their roasting sticks, and they come out. It's actually doomed if you get at that too quickly. The flame ignites the marshmallow, maybe chars the outside of a wiener, and then there's no stable hot area for roasting. Using suboptimal tools, so you got an incorrect diameter stick. It's too thin, too thick. Maybe there's a bitter toxic component. Maybe it's a stick from like a poison hemlock, or it's from a painted coat hanger that you're using. Now, if your marshmallow comes from the fridge or the wieners from the freezer, that's going to really impact and make it hard. Incorrect exposure time. So if you don't expose it properly, it might be nice on the outside, but you're going to have a solid bit inside, and you can never put that into a wafer cracker with chocolates to make a good s'more. And it can catch fire even in an ideal roasting area. And then there could be ashes that adhere to your marshmallow. So if we look at the devices, so there's a stick. Now there's lots of designs that you can have that make this easier and more user-friendly and safe. So this is just a modified coat hanger. Here's somebody that was really creative. They used their rake and put some wieners on it. And this is the type of approach that really creative people take. So like, such as my wife, these things are purchased just for roasting marshmallows. They come out sterilized, individually wrapped, all set for the kids. These are things that make it better. So I got this, how to roast the perfect marshmallow, on a Google search, and it's from The Art of Manliness. And it basically summarizes what I said. So you got to pay attention to the right tool, prepare your tool properly, prepare your fire properly, get a nice area and use a proper motion when you're actually rotating and roasting. Get the best consistent place where it's going to be like a hot box. And then make sure you don't burn the outside, and ta-da, you've got a great roasted marshmallow if you follow each one of these steps. So how about if we make this analogous to vitrification, cooling and warming, as we've seen in the previous talks. So cooling and warming solutions, if they're at an inappropriate temperature, so maybe you didn't warm it to room temperature from the fridge. The thaw solution isn't maintained at physiological temperature because you've got a lot of embryos that you're freezing for, or a lot of eggs that you're warming for this particular patient, and so you don't return to the right temperature or have two of your dishes prepared. Suboptimal tools for the preparation. This is actually less of an issue in our earlier days when we had to do a lot of preparing our own carriers. Now we've got a lot of support from commercial sources, but perhaps labeling or uncapping your device, you didn't think of it soon enough or do it properly, and so you're moving too quickly to get that ready for your last step before you load it. Incorrect exposure time, maybe you lost sight of an embryo or one of the 2 or 3 oocytes that you were looking for, or challenges with the loading, or allowing your liquid nitrogen bath to evaporate. So if you're doing a bunch of procedures or a bunch of oocytes, bunch of embryos, and you don't top it up, it does evaporate, and that can allow maybe a risk of you bringing your carrier above the liquid nitrogen when you're capping or when you're doing a procedure. So if we now take this analogous tips for applying it to good vitrification, now we've got tips for successful embryo oocyte vitrification. And this is the clinical embryology-ness of ART. So you want to select your appropriate carrier, whether it's open or closed, and make sure it's labeled and prepared ahead of time. You want your solutions to be at the appropriate temperature and maintained at the appropriate temperature and kept clean. Load your device with a consistent volume. Don't carry over to it, oil over to it when you're loading it. Load it quickly to avoid evaporation, but consistently. And once in the liquid nitrogen, never raise the embryo portion above it. And use a smooth motion, not too fast, not too slow, from the liquid nitrogen to your solution. So how about development and contributions to our field? So in the beginning, freezing and thawing in 1995, solutions were prepared in small batches in-house. I pulled this from a lab manual that I had, I think, in probably around 1995. We made up our own solutions in small batches. There's a lot involved in that, a lot of variability, variable sources of materials, numerous steps. We had 7 steps for blastocyst freezing and glycerol in those days. So now we have commercially available kits. There's large batches, consistent ingredients, including high quality water. Protocols and in the package inserts are extremely easy to follow and extremely easy to use when you're training people. And different companies have different similar types of quick protocols. And these have made things very easy for us. Modification for consistent placement area. So if we talk about our carriers, open and close options are available. There's designs that have convenient label placement. Protocols are in the package inserts. They put markings on some of the tips and caps that make it easier for us to visualize under liquid nitrogen. This is a rapid eye, great for training young embryologists, because that well is just the right size for an ideal volume to load. So that one, even if you're not right into a closed system, the device itself gives very good experience on how much to put on and how to keep track of your oocyte or embryo. And there's closed systems, different kits available, lots of options. So evolution of embryo and oocyte cryopreservation, it's been driven by vast experience with animal embryos. The success has actually also benefited animal projects, endangered species, high-value animals, so it goes both ways. Development of improved protocols, media, carrier devices, they're rapidly moved to broad availability, and IVF has become essential. It's big business. And so large-scale production allows consistency, improved quality control, comparable performance across broad geographic areas, and it can remove one variable when we're looking at changes in results. So I do think our commercial suppliers and partners, they're very important to us. And so the final tips: use your cooling and warming solutions at the required temperature and pay attention to humidity, particularly the thaw solution. Avoid carrying oil from overlay, particularly the vitrification solution. Load embryos and oocyte efficiency and in an appropriate volume. Do not reuse dishes and solutions for too many embryos and oocytes. And track your outcomes by both the cooling and the warming operators, because both are required to success, contribute to success or to contribute to failure. And an impact of some suboptimal technique, it can be very subtle. You see survival, you may see fertilization, but competence can be insufficient for implantation. Thank you.
Thank you. Thank you very much, Scott, for that summary, but also that little campfire chat as well. Just to carry on that sort of analogy, but also thinking about saving time and speed. We have Chris Yang from Texas, who's asked, what are your thoughts on dunking 2 cryo devices in one TS solution at the same time? I suppose we've thought about it at one point or another to save time. What's your uptake for that?
My thought?
Your thought?
Yeah. So I have seen people do that. It's totally possible to do it. I'll take you back to Juergen's presentation. If you put 8 oocytes on one carrier, these carriers are designed. I've seen people hold 2 carriers together, and it can be 2 embryos that they're thawing or 3 oocytes that are thawing at the same time. I would not recommend it as a general practice, but people that do this on a very large scale, I think it's probably acceptable.
You don't think that the temperature will be lowered in the solution, or you think it's just a matter of that step getting out of the way quickly?
I think it depends on how they do it. Certainly, you're talking about there would be variability if you talk about the heat capacitance of the solution. If it's a big enough volume to say something like a cryotop that's very soft, if you put 2 cryotops in there, I don't think it's having a big enough impact on it. I've seen the results from people that do it. I don't think it's a good general practice to do. But if you're thawing 20 oocytes, you also have to get to your ICSI procedure, and there's other components you have to take into account.
Very true.
Most of the time you find 1 embryo, so it's not an issue.
Very true. Okay, thanks. Now I'd like to move on to the Q&A. So I'd like everyone to turn on the cameras and join us. Okay, we've got some time. We've got many questions. Okay, I think I'll go to our first speaker, who was Jeremy. Okay, and ask a question here. This is from Cecilia Wong from Australia, I believe. And it's, do you think oocytes stored in the upper location of a vapor phase tank are more susceptible to devitrification?
I think as long as the temperature is kept below the devitrified temperature, then the vitrified cell should be okay. But for the vapor, you got to be careful about the vapor, because sometimes if there's a wind or something just blow the vapor away, then your vitrified cell will be exposed to the risk for the devitrification. That's my answer.
Okay, thank you.
Yeah.
I would like to ask a question to Dr. Liebermann from Rena Angeli from Greece. The question is, how do vitrification and slow freezing compare in terms of their impact on oocyte physiology and zona pellucidi hardening? And what could be the underlying mechanism causing these differences?
So I think if I would know the precise answer, I deserve a Nobel Prize. But my guess is that, when you vitrify oocytes, a much shorter time still compared to a slow freezing protocol, that exchange of water cryoprotectant happens much faster. So the rehydration happens much faster. Even you would do the conventional vitrification way of about 9 minutes warming. And that means, when you provide water back in the cell, that cellular activity will occur much faster. That will include the spindle reformation, the beta tubulin, all that parts of the intracellular structure comes earlier to life. That's why you see this difference between, slow freezing and vitrification in this 2-hour window.
And so we have the question for the errors. So the audience want to know the KPI more details. I want to ask about the KPIs you mentioned every 3 months. Can you explain more details, please? So the errors give the details for your KPIs.
Yes. First of all, we need to follow its embryologist, its performance, and then overall performance for survival rates for oocytes, cleavage stage embryos, and blastocyst stage embryos. And then we divide this according to the age of the patients. So we have subgroups of patients. Then the egg donation program. As I said in my talk, during my talk, we use cryopreserved oocytes in some egg donation cycles. So we use this data just to feed our system and to understand better how we perform. It's not so fancy KPIs that we need to follow, but we need to follow very, very, very often in order to pick up some discrepancies from the mean performance that we have during the years.
Thank you.
Okay, great. Now, at the risk of going on, I'm going to ask all the speakers very quickly in a few words to tell us, because there's a lot of questions about this, their thoughts or their practice on collapsing the blasts before freezing. Okay, so I'll start with Eros, okay, and then work whichever way you think. So Eros, collapse, yes or no?
Yes, when we need to vitrify an expanded blastocyst, yes, we prefer collapsing the blastocyst 5 to 10 minutes before vitrification takes place. We make sure that the blastocyst collapsed, because sometimes a round of collapsing is not successful, so we need to be sure that it's collapsed. Otherwise, we don't go for another round. We'll go straight forward with the vitrification. For the younger, smaller blastocysts, we have seen that we don't need to collapse.
Okay, Jeremy?
I would say yes, because based on the principle of the free cryopreservation, in order to have a successful cryopreservation, basically we want to remove the water. So collapse, basically it's a process to release the water out of the embryo. That's my answer.
Okay, Juergen and then Scott, please.
Essential. We still see when we thaw blastocysts frozen before we did assisted collapsing, like before 2009, they float on the top of the drop, and this is not a good sign. So even by making the protocol shorter, we want to help the blastocyst to do a good job in this short time window, and when we can apply this assisted collapsing by removing already the water content from the blastocyst, we can move on to the shorter exposure time, where we also reduce not just the workflow or the time in the lab, but most important, oxidative stress too.
Thank you.
I'm going to actually answer it both ways. I spent probably 5 years at my previous facility not collapsing, and I didn't see a difference between, so my current facility, we collapse all of them. I actually didn't see a significant difference in outcome. And my rationale for it is, I think that the blastocele is quite permeable to the cryopreservatives. And so I think you end up getting the same equilibration. But having said that, we do 100% collapsing where I am now, other than the very early ones.
Question that I would like to ask came from Stephen Mullen. The question is, why do you suppose the cooling rate and warming rate are so different? And first, I would like to ask a question to Dr. Jeremy Chang.
Yes. So here, because the temperature difference, because when we do the warming, we warm from the liquid nitrogen, which is minus 196. And then we warm the device, put the device into 37 degrees. So the difference of the temperature will be different from the cooling. So for the cooling, we use the room temperature, so which is starting from 25, plunge into the minus 196. So the warming rate will be faster or higher than the cooling rate. That's the reason.
Thank you. And what do you think, Dr. Liebermann? How would you ask this question?
Yeah, he's absolutely right. You know, when you look at the temperature difference you have to overcome at time of freezing or time of warming, that's where it comes down to with 12 degrees Celsius difference. That makes a difference in these cooling or warming rates. They are twice higher, the warming rates, than cooling rates, or even higher.
Thank you very much.
Okay, I have another question from Carrie. So this question, I several times received the same question from the juniors so far. Why not to keep the embryo and the oocyte in the thawing solution at 37, but at the room temperature? So this question is for the Dr. Hamilton.
Okay, so what happens if you keep it at a lower temperature? Is that what the question was?
Yeah, so why we need to keep the thawing solution at the room temperature, not the 37?
Oh, we do keep it at, it's kept at 37 degree temperature. It has to be kept at 37 degree because it creates that warming differential. To get the rapid warming, you need it for that.
Okay, thank you.
And a question for Eros. And there's a few questions about humidity. This is from Wes Edmonds, I think from Birmingham, USA. Can you comment? I think you mentioned about relative humidity being less than 45% in your vitrification environment. Could you explain that?
Yes, it's the vitrification process is very prone to, it's very sensitive to discrepancies for the lab conditions. We faced some problems a couple of years ago with our air ventilation system. So we had some discrepancies in humidity and temperature during the day. For a long period of time, we had very low, and then we had very high humidity in the lab. And that precise period of time, we had also very affected outcomes, mostly for oocytes. So it has been seen also by other groups. There are some thoughts from EV group, if I'm not wrong, from Marcos Meseguer, and we have some input from that. We know that temperature and humidity can affect, and it's because the volumes are very, very small, and probably it's something that it's not cannot be. We cannot force it. We need to keep the conditions stable.
So much. Another question I would like to direct to Dr. Liebermann. There are a few questions around that topic. In the world of VIT, what happens if we have a legacy sample that is slow frozen?
Yeah, we still get these slow frozen samples, and I will not apply vitrification in terms of warming. Slow frozen samples, if you see, when I showed this curve, how long they get dehydrated. So you have to go through multiple steps of diluting the cryoprotectant. There is no way. I would not touch them and expose them to vitrification. Conventional vitrified oocytes with like 15 to 16 minutes You can warm faster. Instead of 9, you can do it in 3 minutes. That's possible. But slow frozen oocytes, we receive them still. And they are easy to handle. They do well, but they require a well-structured protocol that requires multiple step downs for the warming. That could be 15 minutes or sometimes 20 minutes. It's very long.
Okay, thank you. Thank you for your answer.
You're very welcome.
Okay, so this question is there for the Dr. Liebermann as well, but I want to ask all presenters. This is the basic question. What is the recommended time between the oocyte thawing and the sperm injection for the optimal result? The Dr. Liebermann.
2 hours.
2 hours. Okay. How about the Dr. Hamilton?
I say 2 hours as well.
Okay. So how about Jeremy?
We usually do 2 to 3 hours. It's the same. Yes.
Yeah, finally the errors. What is you?
Totally agree. 2 to 3 hours.
Okay, okay. Everybody said the 2 to 3 hours. It's good to know. Thank you.
The freezing part is essential too. For the trigger time, retrieval 2 hours.
Okay, okay.
Great.
It's good information.
And a question here for Jeremy. So what's the best practice if we're trying to avoid devitrification and we're getting samples, coming from other clinics? What's the actual process in a nutshell where you're taking them out of the dry shipper perhaps and putting them in the dewar? Is there some like top tips you can say and some things you should avoid when doing that?
So when we move in the cryo device around, usually I will make sure the cap is on, just making sure the device with the cap. And then we can just take your time, move your sample slowly. Just do not drop the cryo device on the floor. Even if you have the incident happen, you still have time to rescue it. Don't forget. So you just take your time and move the cryo device slowly.
Right. Okay, thank you.
Yes.
Well, unfortunately, time is passing very quickly, and the one big question I think that we would like to wanted to answer today is, has the vitrification been unlocked? I will pose this question, and definitely what we heard today, simplicity of the process, security and stability is a big thing in the vitrification. Thank you so much to all the speakers, to Dr. Jeremy Chang, to Dr. Juergen Liebermann, Eros Niteros, and Dr. Scott Hamilton. Thank you so much to my great co-host Kanako Okamoto and Giles Palmer. And now I would like to hand over to you, Kanako.
Yep. Thank you, Magdalena. And not forgetting the team from the I3, the organizing the committee of this initiative, who are the Jack Cohen, the Peter Nazy, the Mary-Ann Sebidis, and Thomas Elliott, Frank Harley, the Violet Saula, and Giles Palmer. Thank you.
Okay, thank you one and all. And again, thanks for the presenters who do not stop in their mission, if you like, to sort of inform them. It really is good that we can bring together people who are sharing that practical experience, and they're very willing to do that. So again, thank you very much for the presenters. Join us again on I3. It'll be next week on the 8th of October. Smart fertility. We're looking at egg AI. We're looking at egg activation and le petit insemination, which I believe is short insemination, that new process. So this webinar next week will be sponsored by Future Fertility. So please join us for then. Until then, goodbye.